Hello, everyone. I am a mobile emergency psychiatric social worker. What I mean by mobile is that the cases occur anywhere in the community where crisis is occurring. This can be homeless shelters, personal homes, police stations, holding cells of police stations, my office, doctor's offices, even street sidewalks. My main role is to keep people safe. This is done by preventing or decreasing danger. I make a lot of referrals to various levels of care. Some people may not know that most of the referrals are not to inpatient care. Breakdown got published in October of 2018. I wrote this because I saw a lot of injustices in the clinical setting. For instance, the rate of readmission to emergency and inpatient settings continues to be astronomical. It has been for many years. This motivated me to learn about the macro system. I began doing national advocacy work and connected to top advocates throughout the United States. I heard their tragic stories, and these inspired me to influence legislation. Most of these advocates have family members with serious mental illness. I increasingly realized that there's a huge disconnect between legislators and clinicians. It seems that most legislators are not aware of what the clinicians do and see. Breakdown aims to close this gap. The goals of Bipolar Breakdown are as follows. I'm going to talk about the case of Owen. Owen has bipolar disorder with psychotic features. I'm going to describe bipolar disorder. I'm going to talk about the etiology, treatment options. Finally, I will go over some legislative reform initiatives of Breakdown. The first interview with Owen occurs because police escort him, 29 years old, to my office after they removed him from the outpatient psychotherapy and medication clinic because he was disruptive and verbally aggressive. He's thin. His clothes are marred with stains and holes. The hair on his head and face is long and unclean. He's wearing 3 jackets despite warm weather. He tells me that he tried to do this intake appointment for therapy and doesn't understand why he was kicked out. His thought process then becomes disorganized. He rapidly jumps from topic to topic without logical connection. He goes from talking about his views on airport policies to why the opioid epidemic exists, to why public libraries should not kick him out, to holidays. He goes on and on for a very long time. I'm thinking, if I don't interrupt him, this could go on for hours I don't have. I try to interrupt him. He doesn't allow me to interrupt him. He ridicules me. He tells me I'm not writing fast enough. He asks if I graduated from kindergarten. He tells me that a hospital emergency department referred him to this intake. He flatly tells me that he is manic, but he thinks all he needs is psychotherapy. Ironically, he cannot describe his mood. To me, it seems labile. He shifts from laughing inappropriately to becoming easily angered. I take a moment to excuse myself and call his mother, Martha. Martha tells me that he has been revolving through the door of emergency rooms, inpatient units, and jails, functioning as I see him now without treatment for the last 4 years. I am astonished. I suggest hospitalization. She immediately agrees, but cautions. She says he knows what to say to get the involuntary hold lifted at hospitals. Thus, if I send him, they'll likely release him. I write the involuntary hold paperwork out of his view, fax this to the police, and call the police. Then he elopes. I write another involuntary hold form, this time with Martha's address, fax this to the police, but later find that the police never find him. Bipolar disorder involves alternating or concurrent episodes of depression and mania. Mania or hypomania must be present for at least a week. Bipolar may or may not include psychosis. Mania involves being overly elated, having excessive energy, being easily irritable, mild grandiosity, engaging in reckless behaviors, excessive talking. Depression involves suicidal thinking, anhedonia, decreased energy, decreased motivation, excessive sleep or insomnia, decreased appetite, excessive food consumption, and sadness. Now, it's important to note that to make the diagnosis of bipolar disorder, seeing all of these symptoms is not necessary. The second interview with Owen occurs a week later. This time, he's barefoot and trying to locate the intake office of the outpatient department of the agency where I'm at. I know this because he tells me just outside my office, where I accidentally see him. I confirm for him that there is no such appointment, and the outpatient department does not accept walk-ins. I explain my roles and offer to evaluate him, but he's not understanding what I'm offering. He's disoriented to the situation. He demands that I give him socks, shoes, water, food, a new apartment, and employment. I sense he might elope again, so I offer to help him investigate where his next appointment is, or if he even has one. Similar to last week, he's disheveled and his appearance is bizarre. He tells me to not contact his mother. That's okay. I don't find this necessary just right now. I'm already sensing that he will likely need an involuntary transport to the hospital. He tells me that the hospital emergency department yesterday discharged him to the streets, but he cannot tell me what brought him there. He gives me a dubious explanation. He cannot stop talking. He doesn't allow me to interrupt him. His facial expression ranges from inappropriate laughter to becoming easily irritable. His body movements are restless and animated. He calls me a joke. I don't let this bother me. He yells, "You're writing lies about me so you can do a Section 12. Not happening." In Massachusetts, Section 12 means involuntary transfer or hold. He insults me. He says I don't qualify for my job. He insists that all he needs is psychotherapy and to get back into running. I withhold my suspicion that this would not be enough because I don't want him to get so angered that he leaves. He has not been able to follow through with any intake appointment made by emergency clinicians in months. I ask a colleague to watch him while I fill out involuntary hold paperwork and faxes to police. He bolts from her. I update his mom, Martha. She was unaware that he was at the hospital yesterday. She says that he's not at baseline. He had started college, but now has no job, no money, no friend, no home. I send another involuntary hold form to the police, this time with the address where his mom suspects he'll go. Later, the police bring him to the hospital. Etiology means cause. What causes bipolar disorder? Determining the cause of any illness is not a top priority in emergency services. According to the National Institute of Mental Health, genetics is the dominant etiology. More recently, brain structure has been closely looked at. The largest study ever comparing cortical gray matter thickness and surface area measures in bipolar and healthy brains occurred just in the last 2 years. Bipolar brains showed thinner cortical gray matter in frontal, temporal, and parietal regions in both hemispheres. Decreased cortical thickness in bipolar brains especially affected the left pars opercularis, left fusiform gyrus, and left rostral middle frontal cortex. Reduced cortical surface area, especially in the right frontal pole, was associated with psychosis. The third interview with Owen occurs a month later. This time, the police found him lying in the roadway, refusing to get out of traffic's path. They almost arrested him and realized that my office is not that far off. So he agrees to go there. His chief demands include an apartment, money, food, and for the first time, he requests a photocopy of the entire Diagnostic and Statistical Manual of Mental Disorders, 5th edition. I set a limit there. His speech is rapid. His body movements are restless. He shows the inability to listen and concentrate. He cannot stop talking. His mood and affect are labile. He transitions from laughing inappropriately to becoming easily irritable. His outer appearance is similar to before. He's wearing inappropriate clothing for the weather. For the first time, I'm seeing an overt display of psychosis. He repeats what I say mindlessly. This is called echolalia. He demands that I read aloud everything I write. He's accusing me of writing lies about him. I ask him if he's hearing any voice that may not sound real. He responds, no. But 15 minutes later, he voicelessly utters words for a couple of seconds. I don't think there's a need to call his mom Martha. I'm already suspecting that he needs hospitalization. Out of his view, I fax the involuntary hold paperwork to the police. Usually 2 police officers show up to help. This time 4 officers arrive because they know him. They know how agitated he can get. The presence of guns is enough to prevent him from physically being combative. He must be thinking, there's no point in fighting. As he gets rolled out on the stretcher to the ambulance, he loudly derides me with lots of profanity. I update his mom, Martha. She tells me that shortly after I evaluated him a month ago, he was admitted to inpatient, discharged within a week to her home. He showed her paper prescriptions of medication, but she doubts that he did anything with these. Owen has anosognosia. This means that he lacks awareness of being ill. I commonly hear families saying that their loved ones got discharged just as sick as they were before hospitalization. This is especially true with anosognosia. Medication is often needed for the treatment of bipolar disorder. Psychotherapy might not be enough to stabilize someone. Medication can be mood stabilizing, antipsychotic, or both. Examples of medication include lithium, antiepileptics such as gabapentin, and antipsychotics such as risperidone and prolixin. Psychotherapy can be very effective in teaching and reminding stabilized people to use healthy coping strategies. This is especially helpful when it involves support, education about the illness, praise of strengths, and explores and enhances problem-solving techniques. I often tell clients that medications cannot do everything. I tell them that they would benefit from developing healthy habits. I also encourage that they practice changes in their thinking to become more realistic and positive. Occasionally, I refer clients to partial hospitalization programs. These involve daily, back-to-back intensive group therapy sessions. It usually runs 1 to 2 weeks, with the opportunity to get medication adjusted or to start medication. Unfortunately, this is not accessible to everyone because not all insurance companies cover this level of care. I often refer clients to crisis stabilization units. These are short-term, require that clients sleep over, and are less intensive than inpatient care. The biggest difference between this and inpatient is in how quickly people can access medication. On inpatient, patients can access medication very quickly, within the first or second hour. But on crisis stabilization units, the clients often have to wait about 24 hours since admission, occasionally even 2 days. Everyone on the crisis stabilization unit wants to be there, but not everyone on inpatient wants to be there. This is why there's a locked door there. The supervision level is higher on inpatient. Inpatient includes the capacity for close and continuous observation of patients. The crisis stabilization unit has less supervision. Massachusetts is lucky in that this level of care is available in all parts of the state, but it's not available in all parts of the United States. Residential programs can be state-funded or private. These are very helpful and supportive, and residents are allowed to go in and out as they please whenever they want. This can be limiting because dangerous behaviors might not be prevented or seen by staff members. Anyway, staff can hold and administer medications to the residents. Assertive community treatment programs involve interdisciplinary support and supervision outside of residential and inpatient settings. They involve all-inclusive teams. This means that the social worker, nurse, psychiatrist or psychiatric nurse practitioner, vocational specialist, substance abuse specialist are all on the same team. The nurse can inject long-acting antipsychotic medication to recipients. Crisis management is available 24 hours per day, 7 days per week. A limitation to this is that the supervision is not very high. It's impossible for staff to know where the clients are at all times. It seems that residential programs can give more supervision. This is because the residential programs have the client's beds, food, and personal belongings for them to return to. Thus, monitoring is more feasible. Outreach programs are usually state-funded. They involve supportive housing. This means that residents live side by side and share a common area where they can watch television together, and they're also able to cook together in a kitchen. Home visits are done by case managers and clinicians. The staff can give medication reminders and help with packaging and preparing medication. A limitation of this is that it's not as supervised as the group residential program. There are many non-state funded inpatient units throughout the United States. The lengths of stay have shrunk dramatically in the last couple of decades. The involuntary hold criteria is very restrictive in most states. This makes it very hard for clinicians to connect unstable patients to inpatient. Premature discharges are prevalent. This contributes to the revolving door. When patients are discharged too soon and unstable, inevitably they'll get readmitted. The length of stays on state-funded inpatient units are usually longer than on non-state inpatient. Most of the state-funded beds in the United States are forensic. Some states allow for the direct admission of patients from emergency settings. Massachusetts typically requires that the transfer be from non-state funded inpatient first. The United States faces an inpatient bed shortage. Since the height of deinstitutionalization in the 1950s, the number of beds declined by 96%. This massive elimination of beds occurred despite that the population increased since then. This contributes to excessive waiting times in the emergency setting. Breakdown details discrimination at length. Some patients are prone to violence. Some don't want any help. Some don't have health insurance. Some are expected to pose extremely challenging barriers to discharge. Thus, they will be on inpatient for longer than average. The wait for inpatient will be longer than average for those with these characteristics. It's interesting that certain inpatient units claim that they have extremely low restraint rates. But I wonder if they don't accept the most challenging cases. Breakdown proposes that legal consequences be imposed. Assisted outpatient treatment, referred to as AOT, is usually court-ordered. The court orders outpatient treatment using the assertive community treatment model. The court order is vastly preferred because of the black robe effect. This means that recipients are very likely to follow through with what the judge orders because the judge is in a position of power and authority. The National Institute of Mental Health estimates that 51% of people with bipolar disorder are not being treated. The most common reason for treatment non-adherence is anosognosia. People without insight are more likely to require involuntary care than those with insight. All research I have found on AOT shows it reduces rates of homelessness, incarcerations, violence, readmissions to inpatient, and improve self-care. Therefore, it's unfortunate that Massachusetts, Maryland, and Connecticut do not allow AOT. All other states and Washington, D.C. allow AOT. Owen would have functioned much better if he had been given AOT. Involuntary hold laws are overly restrictive in most states. With the exception of active suicidal ideation, these laws don't prevent danger. Instead, they require that danger be unfolding. Such restriction contributes to the revolving door that Owen enters. He often gets released to his mom's home from hospital emergency departments rather than being moved to inpatient. In summary, I talked about Owen, who has bipolar disorder with psychotic features. I defined bipolar disorder. I talked about possible etiologies of bipolar disorder. I went over treatment options. And finally, I talked about reform initiatives of breakdown. Thank you for listening to Bipolar Breakdown. This is Lynn Nanos. I have just given you a lot of information about bipolar disorder and my newly published book, Breakdown, A Clinician's Experience in a Broken System of Emergency Psychiatry. For more information, please visit my website at lynnnanos.com. Breakdown is available for purchase at all major online stores.